Ever felt like you're just drowning in a med-surg chapter, wishing someone could just, pull out the absolute essentials? Well, welcome to the deep dive. We're here to turn that dense info into knowledge you can actually use. Today, we are taking a deep dive into Chapter 55 of Lewis's Medical Surgical Nursing, the 12th edition. It's all about the male and female reproductive systems. Our mission for you, especially if you're navigating nursing school, is to give you a real shortcut to mastering this. We're talking structures, functions, and really crucially, the nursing assessment and management. Think of this as your guide.
Exactly. Not just the facts, but the understanding behind them. The kind that prepares you for practice, for those clinical situations. We'll guide you step by step, covering pathophysiology, risk factors, which you'll see clinically, the tests, and definitely the nursing management side.
We want those aha moments for you, getting the what and the why so you're ready for patients and, let's be honest, those NCLEX-style questions.
Precisely. So let's start with the basics, a foundational blueprint, anatomy and physiology.
Okay, so when we talk reproductive organs, there are kind of two main groups, right? Primary and secondary.
That's right. The primary organs, they're the gonads. So ovaries in females, tests in males. Their big jobs are producing gametes, the sex cells, eggs, and sperm, and secreting hormones. Then you have the secondary or accessory organs. They handle all the support, transport, nourishment, protection, like for a fetus.
Makes sense.
Yeah.
Okay, let's kick off with the male reproductive system. What are its main jobs?
For males, I think three main roles. Producing and transporting sperm, getting that sperm into the female tract, and hormone secretion, testosterone primarily. And the primary organs, the real powerhouse, are the testes.
Right, the testes.
Yeah, paired organs, usually oval, firm, about 1.5 to 2 inches long, located in the scrotum. Functionally, they're doing two key things. The seminiferous tubules, they produce the spermatozoa, that's spermatogenesis, and then the interstitial cells, they're making the testosterone.
Got it. So sperm's produced there, but it needs to get out, right? There's a whole transport system.
Oh, absolutely. It's quite a journey. First, they mature in the epididymis. It's this long, like 20 feet coiled tube right behind each testes.
Wow, 20 feet.
Yeah. Then they move into the ductus deferens, or vas deferens. That's the bit involved in a vasectomy. It travels up in the spermatic cord, joins the seminal vesicle duct to form the ejaculatory duct. That passes through the prostate gland, and finally into the urethra.
And the urethra in males is the exit for both urine and semen.
Correct, a shared pathway.
Okay, but sperm don't travel solo. What about the seminal fluid, those secondary glands?
Right, the fluid semen is crucial. It's not just transport. You've got the seminal vesicles behind the bladder, the prostate gland just below it, which many men encounter issues with later, like BPH, and then the tiny calipers or bulbourethral glands below the prostate. Together, their secretions make the seminal fluid alkaline and nutritious.
Alkaline, why is that important?
It protects the sperm from the acidic environment of, say, the female vagina, gives them energy, motility, helps them survive the trip.
Makes sense. And then the external parts, penis and scrotum.
Yep. The penis has the shaft, the glands are tip, maybe a prepubes or foreskin if uncircumcised, and, importantly, their erectile tissue, corpus cavernosum and corpus spongiosum. The scrotum is the sac that holds the testes, helps regulate their temperature too.
Okay, clear picture for the male system. Let's switch over to the female reproductive system. What are its core functions?
Similar framework, three main roles again. Producing ova, the eggs, secreting hormones like estrogen and progesterone, and protecting and facilitating fetal development if pregnancy occurs. The primary organs here are the ovaries.
The ovaries, right.
Paired, almond-shaped, firm, maybe 1.5 inches long, on either side of the uterus. And here's a really critical point for nurses to grasp. Women are born with all the oocytes, the immature eggs they'll ever have.
All of them at birth.
All of them. Starts around 700,000, but through a natural process called atresia, that number drops significantly, maybe to 300,000 by menarche, the first period. This finite supply has huge implications for fertility, for menopause, everything.
That really changes the perspective. So an ovum is released during ovulation. What happens next? Where does it go?
It gets swept up by these finger-like projections called fimbriae into the fallopian tube. The tubes are about, say, 5 inches long, and fertilization usually happens there in the outer third typically.
And how long does the egg stick around?
It's viable for up to about 72 hours after release, so timing is definitely key.
Following that path, we land at the uterus. What should we know about it?
The uterus is amazing. Pear-shaped, hollow, muscular organ. Sits between the bladder and rectum. It has 3 layers. The outer perimetrium, the thick muscular myometrium, that's what contracts during labor, and the inner endometrium.
The endometrium, that's the lining that changes with the cycle.
Exactly. It thickens and sheds, crucial for potential pregnancy implantation. And the uterus itself has parts. The
Mhm.
top is the fundus, the main part is the body or corpus, and the lower part is the cervix.
Ah, the cervix. You mentioned its importance, especially that junction point.
Yes, the cervix projects into the vagina. It has an outer part, the ectocervix, with smooth pink squamous cells, and an inner part, the endocervix, with rougher, redder columnar cells. Where they meet this columnar junction, that specific spot is where most cervical cancers start.
So that's why Pap tests target that area.
Precisely, it's ground zero for screening. The opening is the os, and the mucus produced there changes consistency through the cycle, affecting sperm passage.
Okay. And then externally, the vulva and also the breast.
Right, the vulva includes the mons pubis, labia majora, and minora, the vestibule inside the minora, the clitoris, which is erectile tissue, the urethral meatus, Skene's glands near the urethra, kind of like the male prostate, and Bartholin's glands for lubrication, similar to male Cowper's glands, and the breasts, secondary sex characteristics, extending from the second to sixth ribs. Remember the tail of Spence?
That upper outer part going towards the armpit.
Yes. Crucial for breast cancer screening, as that's where most cancers develop. Inside, alveoli secrete milk, which travels through ducts to the nipple.
Okay, solid foundation on the anatomy. Now, how is all this controlled? The hormones.
The hormonal orchestration. It all revolves around the hypothalamic pituitary gonadal, or HPG, axis. The hypothalamus releases GnRH, gonadotropin-releasing hormone.
Okay.
That tells the anterior pituitary to release FSH, follicle-stimulating hormone, and LH, luteinizing hormone. In men, LH is also called ICSH. These pituitary hormones then act on the gonad's ovaries or tests to produce estrogen, progesterone, and testosterone. It's a feedback loop.
Let's quickly at the main roles. FSH.
In women, FSH stimulates ovarian follicles to grow and mature, getting an egg ready. In men, it stimulates the seminiferous tubules for sperm production.
And LH.
LH is the trigger for ovulation in women. It finalizes follicle maturation, causes the egg release, and then helps form the corpus luteum from the ruptured follicle. The corpus luteum then secretes progesterone, which is super important for maintaining the uterine lining.
Then in men, LH or ICSH.
It triggers the interstitial cells in the testes to produce testosterone, which is needed for sperm maturation.
What about prolactin? We hear about it with breastfeeding.
Yes, in women, it's key for mammary gland development and milk production maintenance. In men, well, honestly, its function isn't really known or understood.
Interesting. And the big three steroids. Estrogen, progesterone, testosterone.
Estrogen in women drives secondary sex characteristics and the buildup of the uterine lining the proliferative phase. Men have small amounts, mostly from adrenals. Progesterone is huge in the second half of the cycle, the secretory phase, maintaining that uterine lining for potential pregnancy. Testosterone in men, obviously, for secondary sex characteristics and making sperm. Women have small amounts, too, from adrenals and ovaries.
So what keeps this whole system from going haywire, the feedback mechanisms?
Exactly. Mostly it's negative feedback. High levels of, say, testosterone or estrogen tell the hypothalamus and pituitary to ease up on GnRH, FSH, and LH.
So levels drop.
Right. And low levels signal them to ramp up production. Keeps things in balance. But women have this really cool exception, positive feedback.
How does that work?
High estrogen levels, right before ovulation, actually cause a surge in GnRH and especially LH. That LH surge is what triggers ovulation. It's a unique, critical mechanism.
Fascinating. Okay, shifting to the rhythms of female life, starting with menarche.
Menarche is just the first menstrual period, usually around 12 or 13. Signals puberty. Important for you as nurses to know. Initial cycles are often irregular. Anovulatory, maybe?
And the regular menstrual cycle itself, that 28-day average dance.
It's fundamental to understand. Starts day 1, the first day of bleeding. That's the menstrual phase. Estrogen progesterone is low. The endometrial lining sheds. Lasts maybe 4-6 days. FSH starts rising.
Preparing for the next phase.
Exactly, which is the proliferative or follicular phase. FSH makes a follicle mature. That follicle pumps out estrogen. Estrogen suppresses FSH, but also builds up the uterine lining, again, getting thicker, more vascular.
Okay, lining is building.
Then comes the secretory or luteal phase. That peak estrogen around day 12 causes the big LH surge. Ovulation happens a day or two later. LH also turns the empty follicle into the corpus luteum, which makes estrogen and progesterone.
And if no pregnancy?
If no fertilization, the corpus luteum fades, hormone levels drop, the lining isn't supported anymore, and it sheds. Back to day 1, menstruation.
And eventually these cycles stop with menopause.
Right. Menopause is the physiological end of menstruation due to declining ovarian function, defined as 1 full year without a period, a major life transition.
Let's talk about sexual response and aging, Masters and Johnson's phases.
Yes, a useful model, though remember it's complex, influenced by psychology, health, lots of factors. Starts with excitement. Penile erection in men, clitoral congestion and vaginal lubrication in women.
Then plateau.
Excitement maintained. Erection holds. Penis might enlarge slightly. Vagina expands. Uterus elevates a bit.
Followed by the orgasmic phase.
That's the release. Rhythmic contractions. Ejaculation in men. Uterine and vaginal contractions in women. Interestingly, the cervical eyes might relax slightly.
And you mentioned women can be multi-orgasmic.
Yes, they don't necessarily have the same refractory period, that resolution phase downtime, that men typically do before another orgasm is possible. Resolution is just the return to the pre-excited state.
Now, aging. What key changes should nurses anticipate?
Very important clinically. In women postmenopause, it's largely about decreased estrogen. This can mean breast and genital tissue atrophy.
So, thinning.
Yes, thinning, dryness in the vagina, which can lead to painful intercourse or urogenital infections. Also, reduced bone mass osteoporosis risk and increased atherosclerosis risk. In men, testosterone decline is more gradual. Common changes include the prostate enlarging BPH. Benign prostatic hyperplasia is very common, causing urinary issues.
Like difficulty starting flow or frequency.
Exactly. Also, decreased sperm production, maybe decreased muscle tone in the scrotum, testes might get smaller or less firm, and erectile dysfunction, ED, becomes more common.
So, as nurses, how do we approach this?
Crucially, recognize these are normal aging changes. Our role is education, provide accurate, unbiased info. Challenge negative stereotypes about sexuality in older adults. Offer practical advice, like suggesting lubricants for vaginal dryness. It's about support, maintaining dignity, and knowing when to refer if issues are significantly impacting quality of life.
Excellent points. Okay, let's put on our nursing detective hats for this subjective assessment, getting the patient's story. Trust, confidentiality, non-judgmental attitude are key, right?
Absolutely paramount.
Yeah.
And using gender-neutral terms until you know preferences. Start broad, less sensitive topics first. General health history, then maybe menstrual history, before diving into more personal sexual health questions.
What kind of general health info is relevant here?
So much. Major illnesses, hospitalizations. Immunizations like mumps history in men, which can affect fertility, or rubella status in women before pregnancy. Chronic conditions are huge. Diabetes, big link to ED in men, pregnancy risks in women. Cardiovascular disease can affect function, plus there's often fear around sexual activity post-MI or stroke. Renal issues, thyroid disorders, they all can play a role.
What about allergies and medications?
Definitely ask about allergies, latex and condoms, silicone and diaphragms, even medications like antibiotics used for STIs or UTIs. And meds. Oh boy. Hormonal contraceptives, hormone therapy, need to discuss risks like clots, stroke, certain cancers, especially with smoking.
So many common drugs too, right? Antihypertensives, psych meds.
Yes, many blood pressure meds, antidepressants, antipsychotics can impact sexual performance or desire. Always ask about prescription, over-the-counter herbals, on illicit drug and alcohol use.
And past surgical or treatment history. Obstetric history.
Crucial. Any pelvic surgeries. History of therapeutic or spontaneous abortions. Number of pregnancies, births. Also family history, genetic risks for reproductive cancers like breast, ovarian, uterine, prostate.
Lifestyle choices seem huge too. Smoking.
Smoking is a big one. Linked to ectopic pregnancy, miscarriage, preterm delivery, birth defects, earlier menopause, lower sperm count, ED, even cofactor for HPV. Alcohol, drugs also impact reproductive health significantly.
Okay, let's think about the functional health patterns framework from Lewis. How does that guide our questions?
It's a great systematic way. Health perception management. Do they do breast or testicular self-exams? Are they up to date on pap tests, mammograms?
Nutritional, metabolic. Assess for anemia, especially in menstruating women. Eating disorders. Anorexia can cause amenorrhea, osteoporosis, obesity linked to PCOS, diabetes. Ask about folic acid, calcium, vitamin D.
Elimination. Any urinary issues.
Yeah.
Incontinence, common in older women. Recurrent UTIs. Difficulty voiding like with BPH in men.
Activity exercise, risk for osteoporosis. Female athlete triad amenorrhea, low energy, bone loss.
Sleep rest. Disrupted by postpartum changes, hot flashes, nocturia from BPH keeping them up.
Cognitive perceptual, any pain. Pelvic pain could be PID, cysts, endometriosis, dyspareunia, painful intercourse, common postmenopause.
Self-perception role relationship. How do they feel about body changes with aging? How are family dynamics, work stress impacting them?
And the big one, Sexuality, reproductive.
Here we need a detailed menstrual history. LMP, cycle length flow, menarche, menopause status, obstetric history, G's and P's, gravidipora, abortions, and the sexual history using the 5 P's. Partners, number, gender, type of relationship, practices, vaginal, oral, anal, protection from STIs, past history of STIs, and pregnancy prevention or plans. Ask about satisfaction, beliefs, orgasm too.
And finally, coping stress and value belief patterns.
How do they cope with stressors like infertility, pregnancy, and STI diagnosis? What are their support systems? Any cultural or religious beliefs influencing their choices or care needs?
Let's quickly apply this. Remember CW, our 23-year-old with pelvic pain, irregular bleeding.
Right. Subjectively, key data includes OCP, use but forgets pills sometimes. Menarche at 12. LMP 2 weeks ago, but bleeding irregularly for months with increasing pain. Sexually active with men and women, 6 lifetime partners, currently monogamous with male partner, 2 years, vaginal oral sex.
See how that history immediately flags areas like adherence, bleeding changes, pain, and STI risk factors, even in a monogamous relationship currently? That's the power of good subjective assessment. Okay, now on to the objective assessment. What we see, what we feel, gloves on, maintain professionalism, ensure comfort.
Always. For the male exam, inspect the pubic hair distribution, skin for lice or lesions. Inspect the penis and scrotum, look for lesions, discharge, swelling. Check the urethral meatus. If uncircumcised, gently retract the foreskin, look underneath, and crucially replace it afterwards to prevent problems like paraphimosis. Palpate the scrotum. Testers remember the left usually hangs lower, feel for tenderness, masses, and recall cryptorchidism risk for cancer. Inspect the anus too.
And for the female physical assessment, breasts first.
Usually, yes. Inspect seated. Symmetry, size, shape, skin color, vascular patterns, any dimpling, retractions, lesions. Have her do maneuvers, arms overhead, hands on hips, leaning forward. This can highlight abnormalities. Then, supine position for palpation. Use a systematic pattern like vertical strips using the pads of your fingers. Cover the entire breast, including that tail of Spence towards the axilla.
That upper outer quadrant again.
Exactly, where most cancers arise. Palpate the axillae and clavicular areas for lymph nodes. Note any nipple discharge color, consistency, and always reinforce breast self-awareness with the patient knowing they're normal.
Then the external genitalia.
Inspect mons pubis, vulva, perineum, anus, hair distribution, lice, lesions, redness, swelling, discharge. Gently separate the labia to see the clitoris, urethral meatus, vaginal opening, introitus. The internal pelvic exam, speculum, and bimanual is typically done by NPs, PAs, physicians. Speculum allows visualizing vaginal walls and cervix, collecting PAP and STI samples, often that is now. Bimanual exam uses 2 hands, one internally, one on the abdomen, to assess the uterus and ovaries for size, shape, consistency, tenderness. Normal ovaries usually aren't palpable postmenopause.
And being aware of potential abnormalities is key for nurses, even if we aren't doing the internal exam.
Definitely. For females,
Yeah.
discharge changes suggesting infections like BV, yeast, STIs, growths like warts or chancres, redness. Pelvic pain could be PID, ectopic, cysts, endometriosis, fibroids, cancer. Breast changes, dimpling, nipple issues, masses.
And for males.
Inguinal masses could be a hernia or swollen nodes. Penile discharge urethritis, penile growth chancre, chancroid, warts, cancer. Scrotal masses, epididymitis, torsion, emergency, hydrocele, varicocele, cancer. Redness would be infections or infestations.
So, back to CW's objective data. Vitals normal, thyroid slightly enlarged, might need follow-up. The abdomen, okay. External genitalia normal, but the bimanual exam. No cervical motion tenderness, but pain on the left side, and a palpable soft mass consistent with an ovarian cyst.
So you have the physical exam findings, especially that localized tenderness and mass, refine the picture from her history. Now we need diagnostics to confirm.
Right, the diagnostic toolkit. What tests help us figure things out definitively? And what's our nursing role?
Our role is huge. Patient education about the test, what to expect, why it's needed, ensuring proper preparation, maybe NPO, maybe specific timing, and post-procedure monitoring, watching for bleeding, infection, pain, giving discharge instructions.
So what kinds of tests are common? Serology, blood tests?
Yep. Hormone levels are big. AMH for ovarian reserve PCOS, estradiol, FSH, LH, progesterone, prolactin, testosterone for gonadal function, infertility, pituitary issues, HEG for pregnancy confirmation or molar pregnancy, and PSA in men for prostate screening.
What about imaging? Radiologic studies?
CT and MRI give detailed views of pelvic structures, looking for tumors, abnormalities. Mammography for breast tissue. Ultrasound is incredibly versatile breast, pelvic, transvaginal for things like ectopic pregnancy, ovarian cysts, fibroids, testicular ultrasound for masses or torsion. Rectal ultrasound for prostate.
For CW, that pelvic transvaginal ultrasound would be key.
Exactly.
Any other procedures?
Lots. Colposcopy gives a magnified view of the cervix after an abnormal pap. Colonization, or gate, actually removes cervical tissue for diagnosed treatment. D&C scrapes the uterine lining, often for abnormal bleeding. Hysterosalpingogram, HSG, uses dye to check uterine cavity and fallopian tube patency common in infertility workups. Hysteroscopy directly visualizes the uterine lining.
And laparoscopy, you mentioned that before.
Right, small incisions. Camera goes in to look at pelvic organs, used for diagnosis like PID, endometriosis, or perceivers, tubal ligation. Remember that referred shoulder pain from the CO2 gas used as common warned patients. Biopsies can also be guided by ultrasound for precision.
What about swabs and cultures? Cytology.
Cultures and gram stains identify bacteria in STIs or UTIs. Nate's nucleic acid amplification tests are super sensitive, the go-to for many SPIs like chlamydia and gonorrhea using urine or slobs. Pap tests for cervical cytology, often with HPV testing now. Wet mounts look directly at vaginal discharge under a microscope for yeast, bacteria, trichomonas.
And specific fertility tests.
Things like tracking basal body temperature, BBT, to pinpoint ovulation, semen analysis for sperm count motility, and urinary LH kits, those ovulation predictor kits.
Okay, let's wrap up CW's case. Her diagnostic results. Urine pregnancy negative. Urinalysis normal. CBC shows slightly elevated WBCs, maybe inflammation. TSH normal. STI panel all negative. The pelvic transvaginal ultrasound confirms a 4-centimeter ovarian cyst on the left, otherwise normal uterus ovaries with good blood flow.
Perfect example of how diagnostics confirm the suspected finding from the history and physical, while ruling out other possibilities like infection or pregnancy. It gives a clear clinical picture.
So recapping this whole deep dive, we've covered a lot. Anatomy, hormones, life cycles like menstruation and menopause, aging impacts, and really focus on that nursing assessment, subjective and objective, plus the diagnostic tools.
It really highlights how interconnected everything is. Understanding the normal physiology is the foundation for recognizing the abnormal.
And the key clinical takeaway for you, listening, is that nursing care for reproductive health requires not just knowledge, but real sensitivity, sharp assessment skills, and awareness of the whole person psychologically and socially too.
It's about providing that holistic, patient-centered care.
Which leads to our final thought for you to consider. As a future nurse, you're in this unique spot, bridging complex medicine and individual patient experience.
So how will you use what we've talked about today? Not just to treat a condition like CW cyst, but to truly support your patient's overall reproductive and sexual health journeys, empowering them with knowledge and respect no matter their age or situation.
Something to think about. Thank you for joining us on this deep dive. We really hope this helps you feel more confident with this crucial area of nursing.